Oh, good morning. I'm Amy, the director of the LAVC. So usually we do have our co-chairs. They're not on. Oh no, I see Tony here. Tony Hicks is our co-chair here for the Health and Wellness Working Group. So we just want to inform everyone of the training that's taking place today. We're going to be discussing vaccine hesitancy, talking about why do veterans and others have hesitancy about the COVID-19 vaccine. So we have a wonderful team. And introduce yourselves.
I'm Dana Ayer. I am a sociologist. I'm one of the co-founders of the Global COVID Conversations Learning Network. I'm a 28-year Army veteran.
Good morning. Can you hear me?
Active duty and reserve. Sally, Sonny, Jeremy.
Hi, everyone. My name is Sally Hammett. I'm the Chief of Social Work Service at the VA Greater Los Angeles Healthcare System. And some of you, I think I've been to some of your collaborative meetings in the past. I was here in 2019 as acting SIRS chief here at Greater Los Angeles, working with the homeless population of veterans and the staff here at GLA that serve those for a little while. And you guys reeled me back to LA. So now I'm in a different role, but still collaborating a lot with community organizations and certainly as the chief of social work here at the facility. My role as it relates to vaccination and COVID, when I came here, we were well into the pandemic, and I was asked to help facilitate and chair a work group to ensure that our veterans and our staff had communication efforts targeted toward preventing spread of the COVID and also ensuring vaccination efforts and the communication of those efforts across our healthcare system with staff and veterans. So it's great to be here, and I look forward to this topic. Stony, Jeremy?
Hello, can you hear me? Okay, hi. This is Sani Meckham. I'm a White House Presidential Innovation Fellow detailed to the Department of Veterans Affairs. And I have been working with Sally and others at the Greater Los Angeles Healthcare System to think about innovation and how we can better serve our veterans and support our employees who serve our veterans. And when the pandemic hit, a lot of our focus turned to the community and obviously, like Sally was saying, making sure we were prepared to get shots in arms, but also knowing that one phase of a pandemic is going to be when then we have people who are willing to get the vaccine. And so how can we address this hesitant population? And as we were brainstorming that, I remembered my participation with Dana and Jeremy and others in this Global COVID Conversations Learning Network. And so we all came together in partnership to partner with the community in how we can address hesitancy and maintain agency with our veteran population. So that's my role, and I'm very happy to be here.
And hello, I'm Jeremy Rossman. I'm a virologist, and I've been working with this group for quite a while, really looking at what we can do from a scientific standpoint in getting information about the vaccines, about questions and concerns that people have, and how we can get that information to the people that need it. And we've been working on this model of trusted conversations using community organizations to really facilitate that information flow. So I'm here as a virologist, as somebody that's worked on virus research, immunology, and vaccine vaccines for about the past 20 years, and I'm happy to answer any questions. And so I'll hand that back off again. Thank you.
Okay, Amy, would you just like us to jump into our initial talk, or do we want to go through and introduce the rest of the group?
Everyone can introduce themselves on the chat and then continue with any questions moving forward.
Okay, then we'll jump ahead into our presentation. Yep. Okay, let me get share screen here and go to PowerPoint. And I'm hoping what everyone is seeing now is the start of the start of the briefing. Is that correct?
Dana, I can see the slides just fine.
Okay, good, because I'm sorry, I'm not familiar with this swap card system, so it's not showing me you there. I'm going to be the primary voice here, but I want to emphasize that this really has been a collaborative learning process throughout this entire effort that we've undertaken in support of the GLA VA healthcare system. And so what I'm talking about really is our evolving collective understanding. And we want to emphasize conversations that change. That's the critical theme as we go through this. Obviously, this is the standard. I'm sorry, I am, impeded by 28 years within DoD, so you have to state your purpose up front. No big surprise here, but this really is trust-focused conversations. That's what we'll keep coming back. Those tools, how that works as a tool in supporting change. I'll just say from the beginning, I mean, we all bring different things to this process. At the end of the presentation, there's a slide of the core group here. My particular background as a sociologist has been working in peace building, counter radicalization, and social change. And unfortunately, part of the vaccine hesitancy dynamic is far more similar to radicalization in the conflicts that we faced, AQ and ISIL and others, than we would want to necessarily acknowledge. But there is a process. But the good news is then that we understand the change process that we need to have. We'll walk through in this, take about 20 minutes to half an hour probably. I've got some new material in here. We'll walk through how we see the problem. We'll walk through the process of change, a little bit about our larger program with the VA, and we'll talk about the process of doing conversations. Then we've got a lot of information available at the end. I was not able, I should say, to find a way with the swap card system to post this presentation. More than happy to distribute it if anyone who is kind of more familiar with the swap card or the network can tell me how to do that. Not going to go into a whole lot of detail here, but I just want to highlight, as we all know, the past year, 2 years, 3 years, depending on, we've had some turmoil in society. We have been distracted by a variety of things. And what your worries are may vary depending on where you are, depending on your network, depending on your politics, depending on your economic system. There's plenty of things to worry about out there. But the point is, we really have had this, what we call an ecology of anxiety and opposition, right? Increasing polarization, increasing worry, increasing focus on problems and a sense of confrontation and those sorts of things. And the reason that that's important, and we start with that, is because vaccine hesitancy is, of course, a real issue about vaccination. But psychologically, we don't have multiple buckets to put multiple worries in. We have one big worry bucket into which all of our anxiety about all of our issues drops. And so the more anxious we are about anything, the more anxious we are about everything. And so that is a central factor in the rise of vaccine hesitancy and vaccine concerns from, traditionally it's been a problem. And Jeremy has worked in this for 20 years. It's been a problem. It's a global problem, but the scope and scale of the problem is related to the particular dynamics of the moment in the United States. And we'd highlight that. There's a range of people and attitudes towards vaccine. I'm over on the left there. I'm on the evangelistic side. That's why we started this process. When vaccines first came out, I'm caring for my 95-year-old dad, went out and got him in. As soon as I could get in, my wife could get in, we went down. So we're off on that side. There are a lot of people who are in that kind of worried middle, right? They have genuine concerns, genuine issues, and then off at the side, just like there are the evangelistic, there are the very deeply skeptical. And this profile isn't unique to vaccine hesitancy. This is a pretty standard profile about any kind of activated issue in which you're engaging lots of people. And the whole key to success, depending on how you define success, is what happens to that middle population there. Just a very quick insight into the dynamics of hesitancy and at the extreme resistance. Obviously, at some level, it is an individual factor, but it's also a social factor. At an individual level, we see, there are the perceived threat of the disease and the attitudes towards the vaccine, the confidence in the vaccine. That is driven by a lot of factors. The first thing that we would emphasize is there are a lot of real concerns. As we talk about this, while there are some folks over at that extreme side that we call the resistant, that may have things that for most of us seem, unreal. Overwhelming people who are dealing with this, the concerns are real concerns. What come out of in terms of what their social situation, what their information flow is, in terms of where it comes from, that shapes the specifics. But we would really emphasize that interaction between real concerns and overall level of stress and anxiety. Ironically, no is a mechanism of control. And we emphasize this issue of agency, of capacity, of a sense of control. Vaccine hesitancy is a problem, or vaccine uptake is a problem of hassle and hesitancy, right? The difficulty of getting it plus the issues of hesitancy. What we emphasize, our phrase and corresponding, is access and agency, right? The access piece we have taken care of collectively, right? It's relatively easy to get the vaccine now, certainly far more easy than it was before. But the agency issue, the sense of having the capacity to make a reasonable decision, having the psychological space, that's where we still can work and support. At the center of it is trust. This is not an information problem. The information is out there. It's almost impossible to avoid tripping over messages about vaccinations and uptake and everything like that. So it's not an information problem. It's a trust problem. Dr. South is an African-American physician in Pennsylvania who herself was hesitant and talks about the process of getting information. Katie Atwell is in Australia, and Heidi Larson is one of the global experts in the issues of vaccine hesitancy and confidence, and is based in London. So this is a broad global problem, and trust is at the center of it. Why conversations? What is it about conversation? I mean, conversation, we are social beings, right? And conversation is not just, we all are kind of familiar with that model of conversation and communications that we all get at some point in any education or training we have, where there's an idea in one person's head and it goes through some noise and comes into the idea in another person's head, where it's a very information focused model of conversation. But as my wife keeps reminding me when she says I don't talk enough, fundamentally conversation is also about an emotional bond. Right? It is about a connection. It is about a sense of being together and addressing issues and those kinds of things. So conversation is about opening the space for information. That's why we talk about rebuilding trust chains. Just as we had to learn the concept of cold chains early on in the process, we have to think about trust chains so that information flows through trust chains, and conversation is centered, is central to rebuilding trust chains. This is the project that we're undertaking with the Greater Los Angeles VA, right? And it's just trying to help scale these conversations right now. And we can talk about the model, but the model really isn't critical. Ideally, we have a trusted convener, right? That there is an organization or an individual who has an existing trust, that then we bring in a facilitator, somebody who knows how to conduct conversations, and a subject matter expert and that kind of thing. But that's the elaborate model of it, and this is kind of the organizational effort that we're trying to do. It's why we're talking to you today. But at the core, at the organizational level, what we want to line up is experts, trusted conveners, and hesitant individuals. And we can talk about, if you're representing an organization, we can talk about supporting your organization in doing this, but at the same time, we're talking about conducting individual conversations here. The one point that we would want to emphasize is that, again, the dynamics of trust, who can be a convener, how you tap into existing trust networks. The aim, and if you've been tracking the numbers recently, you know, the Biden administration talked about the kind of politically advantageous and simple story of 70% by the 4th of July. Who knows where that came out of. But our kind of overall target and our overall understanding, based on, and again, this is Jeremy's expertise and everything, based on the dynamics of community immunity, right? What it takes to really of the virus in the community is somewhere around 75 to 85% of the community. And that depends on what percentage of the population. You know, we don't really know how absolutely infectious the new variants are. We don't know how many people have had asymptomatic or unreported cases. So we don't have an exact number about that. But what we do know is we're at, depending on what you're looking at, where you're looking, your geography, about 50 some odd percent in the United States as a whole, if I remember right. I'm down in San Diego. We're about 75% in the county. Kern County and Bakersfield at the far northern edge of the GLA territory is still, I believe, in the 30s. So we're dealing with that group that is to the right of the acceptance curve, right? On the hesitant to deeply skeptical side. So that's where we're talking here. There is a sense right now that, okay, we're done with this, right? We've opened up in California, we've opened up in the United States, but what we're also seeing is cases coming back up, concern around schools, concern around winter, concern around variants and things like that. So we're in the struggle for the last 10%, the last 15%, the last 20%. Again, we don't know exactly how much, but that's the effort we're going. The one thing we would really emphasize is that this process, and we've talked to a lot of peer support groups, that this process is not about making sales, and it is not about providing fundamentally about information. It is about the critical role of peers in any change process. And what peers do is this process of having a shared identity, having a shared background, having shared experiences that then enable a sense of a common process of reflection and engagement, and therefore information flows. And that information flow, it validates the sense of the individual, their identity, their concerns. It helps people reframe or see problems in new ways. It provides encouragement, and that then enables both coping and change. And that really is the core process, and it is applicable to this process as well. this is not a matter of quick conversations in which you kind of hand over the pamphlet, right? This is around, we really would emphasize that this process works based on that emotional processing, not so much the information. So conversations that change, understand the problem, a conversational approach. The outcome of the conversation is not so much vaccine uptake. Obviously, we want that, but it is openness to change. That's the psychological and the sociological effect that we want conversations to have. Would emphasize first, do no harm, right? That when you are using existing relationships, and particularly existing relationships with populations that are troubled or having difficulties, there are multiple goods that are sought through those peer support and agency relationships. And so we're talking about using them, but not abusing them, right? This isn't the only good that we're trying to achieve. If you're trying to working with the homeless population or some other troubled population, there are a lot of things that you want to achieve. They are conversations with a purpose, but it's not sales, right? It is not about making the sale and pushing them. It is about a genuine, trying to create that genuine space for reflection and thinking and modeling of behavior, using all of the techniques that any good, counselor is trained in, and any active friend actually kind of does naturally, right? Listening and empathy and those kinds of things. This is not about a denial of your limits or your concerns, right? In fact, it's the other. It is coming from a genuine place of relationship, modeling your own thinking, and then potentially connecting to resources, both information resources and actually the logistic resources of getting the shots. People have a strong preference for talking to their healthcare provider, but we don't always have healthcare providers that are available. Now, in your particular organizations, in your organizational capacity, Jeremy Rossman, again, as he introduced himself, he both is working with a small and is focused on these kinds of dynamics, but he is also connected to the National Scientist Volunteer Database, group of about 10,000 scientists that are available, that have a broad range of expertise, virologists, but also scientists of all sorts who are interested in supporting the broader anti-COVID effort. And so if you've got particular concerns or a group or anything like that, Jeremy, you have access to resources that are both expert and have a particular tie to whatever, if you're working with an identity group or an experience group or a community or something like that, they have ties and common identity. So we can build on that. And there are a range of real issues. Every time we open the paper, okay, now there's another concern about the Johnson & Johnson, and if I remember right, it's older men that are potentially have this particular side effect. Again, very small, but there would emphasize real concerns. Very quickly, some specific things around answering questions and moving from doubt to trust. And that is a process, right? There is an arc in answering questions, in acknowledgement and validation. We come back to, again, fundamentally, this is about real concerns. And the first step is that the concern is reasonable, it's heard, it's taken seriously. Then you want to say, okay, now here's information, and here's and if you have expertise, obviously, or you have an expert access, this is an arc for them, but there is the information, or it may be and it's also reframing, right? So that is saying, have you thought about this? One of the things we know psychologically is people respond to new information, right? If you are providing people with the same information over and over again, that actually increases resistance. But when you can reframe it and say, well, what about this, or what about that, or hey, here's a new piece of information, have you thought about it this way? That opens up our brain, right? And it helps us to reframe it. So you don't want to just pound away at the same information over and over again, because that just consolidates opposition. You want to help people go, hey, I hadn't thought about it that way. Oh yeah, maybe I can rethink. So that's about reframing. And it's about, and we are getting, I think one of the profound things that is not fully understand is just how much learning is ongoing at this time, right? About the vaccination. We have an unprecedented degree of vaccine surveillance. The multiple systems, both the traditional CDC systems, but also new systems. I mean, we all have on our smartphone the ability to download a system, an app, and through the vSafe system, report our side effects. And so there's a huge awareness and tracking of these things. That's part of the reason we have the detailed understanding of the various side effects that happen in the 1 in a million to 1 in a 2 million rates, right? So we're reframing new information, reframing about evolution of variants that we've heard, reframing about not politics, it's our community and neighbors and everything, right? And one of the things generally we want to talk about personalizing risk, right? Our brains are not very good at abstract numbers. And I'm a quantitative sociologist and I'm aware of my limits, right? We don't think naturally quantitatively. We think about in stories. We think about my friend's father died. My friend at Starbucks had a long COVID. Both of those are the stories that I use, right? That in terms of personal risks, the long COVID particularly is a new piece of information that we've learned, right? And it's not, we don't talk about community immunity. We talk about the health of the people you care about and planting seeds, right? So long COVID is one of the pieces of information that research tends to indicate helps people reframe and rethink. But what we also know is, there are essentially no deaths among the vaccinated. There are some, but 99% or more of current COVID deaths that are among the unvaccinated. And, again, it's not about denying the risks of side effects. It's just to contextualize them and talk about relative risk, right? And again, that's not a particularly powerful thing just because our brains don't really accept quantitative numbers very well. The elephant in the room, pun intended, is obviously the politicization of this. There is a distinct pattern to hesitancy, but we deal with that in the same way, right? I mean, there are issues, right? It's listen, validate, and reframe. And in terms of the particular alignment of the GOP or the conservative wing, again, the same things, personal capacity to decide. This is not about the government telling you. This is about us as people, as a community, talking about this. The concerns about the politicization of science are absolutely reasonable, right? If you know the history of science, been all sorts of challenges, right? Plenty of flaws in the pro-science and Biden administration messaging where you're trying to tell people that they're wrong for not listening, right? We could talk about the Trump administration and the GOP's fundamental credit, right? Which is one of the huge mistakes I think the Biden administration is making in this. The Trump administration invested in Operation Warp Speed. We had long prior bipartisan investment in mRNA research for 2 decades, bipartisan support. And then that meant that the Trump administration could drop the change and push that, and we could get this vaccine. There are plenty of GOP and evangelical voices out there. And one of the things, again, we know is that change, even for politicized issues, change works through extended conversations, right? It's because we open up, if we think about anxiety as a knot, and everything gets tied up, the first thing you want to do is untie the knot, is take the tension off of the knot. You can't untie a knot before you take the tension off. And that means both extended conversations and not selling. It's just opening up. Second dose is obviously another issue as well. Talking about 10% of the population that hasn't gotten the second dose. A lot of things there around the assumptions about good enough and everything like that. But this is, again, one of the things we have been learning through this process. New information helps us change. We're talking about the increasing vaccination model, right? This is where we're working. Practical issues, for the most part, have been settled, except for some populations in some particular areas. But addressing what people think and feel, and addressing the social process, right? The sense that we are in this together and that we are addressing this together is important.
Hey, Dana.
Yeah, go ahead, Sally.
Before you go on, if you could
Yep.
go back to the last slide, because I just want to reflect on a question that's in the chat box. There was a question around what information do we have regarding ethnic and/or religious groups who are hesitant about taking the vaccine.
We have several of those at the end. Thank you, and I'm sorry, the way the thing works, I can't see the chat when I have this on full screen.
Keep an eye on it for you.
Okay, yeah, no, we have information about that. There are a couple of resources that are in the slides at the end. There is one particularly good one at the University of Minnesota, if I recall right, because they have a refugee and immigrant center there that focuses on all sorts of populations. But we also have access in our links to issues for women, for African Americans particularly, because of specific issues there. But we do have a variety of bits of information there, or points of information. And this is the reframing, right? We want to help people think about personal consequences and community consequences and change perceptions of relative risk, right? So that all of those things come together to shape the likelihood. Where we are, off to the right there, that's an announcement from a British organization about, at that time it was still being called the Indian variant. The World Health Organization and the health organizations have started the Greek labeling of the Greek letter labeling of variants, right? So that you don't think about where a particular variant happens, because that can be inaccurate, right? Spanish flu did not originate in Spain, may actually have originated in Kansas of all places. So it's the alpha, beta, the gamma, the delta, the delta, the big one there is the one we're really wrestling with. And we need to help people understand the problem of hesitancy, but also maintain a sense of optimism. I mean, we really are making progress, but we haven't crossed the bridge yet. So that's the balance there. Whether we're fighting for the last 5 or 10% or the last 15%, it's not quite clear, but it is, we are fighting to finish the job. Information sources, here is particular access for the American Medical Association on hesitancy among African American patients. Here is the one that I was talking about, the University of Minnesota. A lot of these other ones also have, the Mayo Clinic and others also have information for specific subpopulations. Here's one for the American College of Obstetrics and Gynecology for women. So there are some specialized ones in here. If you've got a population that is not touched on, one of our colleagues in this effort, Sarah Citronbaum, we call her our information omnivore. She has it at her fingertips. This is a good source in just terms of data. We've got this kind of quick FAQ focused on the Greater Los Angeles VA. We also have access. These are state of California and county pages and this is just the broader catchment area for the Greater LA. So we've got that information there for you, and that's the talk. And here are the partners, and we're all available. All right, that's it. Thanks so much.
Dana, just to chime in on a couple of things that you said, first of all, I'm recognizing that, probably most of you, if not all of you, are veterans. And so first of all, thank you for that. Thank you for your service. I personally wasn't one of the brave individuals that signed a blank check up to and including my life for others' freedom. So that is not something that I take lightly. my father was a veteran, and one of the things that I've noticed here in my time at the Department of Veteran Affairs is that there's a certain that's gained amongst veterans, that as a clinician throughout my work, the past 20 some years as a clinician, I have not really been able to reach folks in a way without taking a very long time at building that rapport and building that relationship. And sometimes it happens quicker than others, but I think that speaks to the lens of trusted conversations in that, this group that we're speaking to, you're poised with this ability to bring to the table this level of trust and engage in these conversations with veterans. And so, first of all, that's really appreciative. Prior to coming to the VA, I worked for the Federal Bureau of Prisons, and as you were talking about, the comment you made about your wife, Dana, and how it's evident that, there's this emotional connection that takes place. During my time in the prison system, when I look at the greatest consequence in prison is solitary confinement. And, I think that is because we are social critters, and that emotional connection while people are still incarcerated is still something that, there's still that connection, and that at times keeps people moving forward and keeps them going and working towards something bigger. And so, as you engage in these trusted conversations, I just want to bring up a couple of things that the VA did that were very successful. Early on, we were having some consideration around, different ethnic groups, as you brought up in the chat, and some concerns around receiving the vaccination. And so as a group, we decided to engage in these lunch and learns where we brought people to the table that represented those groups. So we had, African-American physicians that talked about being concerned about the vaccine themselves, and they talked about working through that process. They talked about their side effects. And as that time went on and we had more of those lunch and learns and trusted conversations, we started to see our vaccination rates rising. And that provided a really nice forum for people to just be heard and to be understood. And so, Dana, as you talk about, the role is not to convince someone or throw a sales pitch. I really think those ongoing and consistent conversations with trusted individuals have really gone far here at the VA, not just with staff at the VA, but also in our efforts toward town halls and group conversations with veterans as they're engaging in healthcare. So, again, I appreciate all your service and your willingness to engage in this dialogue. Looks like I see another question in here, and Jeremy, I know you're on, and Sony and Dana. How does one combat the mistrust that has been bred through the language used by leaders and cynicism and divide that exists in the country today? Wow, that is a great question, Rhonda.
This is where the bringing the conflict communications perspective to this is relevant, right? Luckily we're not as polarized as Sunni and Shia in Iraq, but even there, the issues that we have to do are about kind of re-emphasizing common identities, re-emphasizing common stories. So that's the larger piece, and it's actually something that I'm doing some work in. But so I don't want to go too deep down to that. In the context of the vaccine, I think the point of really emphasizing, look, this is a genuine bipartisan thing. That there is, and I say this as a guy who voted for Biden. The Trump administration did some good things. I fundamentally agree with some of their points on China, and they invested early in the vaccine, and we led the world in that process. right? That's huge. That's important, right? So it's like, why can't we just say that and say, okay, it's a good thing he got vaccinated? There's lots of, Republican senators. I can't remember the names, but there was the guy from Montana was one, several who are saying it. So let's just talk about that and kind of try and diffuse. Again, the logic is to stop pulling on the damn knot is the first thing. And we can't do that collectively, but we can do it individually, right? And acknowledge the emotional energy and acknowledge it and just kind of go, okay, but how does that affect us talking together and you talking with someone who's older, or worrying about the fact that it is, kids are increasingly getting it, right? So you try to diffuse it and open it up in this context.
So can you hear me?
Mm-hmm.
Just have a question on that. I was the one who put that question out there. The thing is that media has done a really good job, and we're not talking, well, I mean, both sides of the media have done a really good job at either saying this is okay, or they're just putting a tracker system in you, Bill Gates, that type of thing. And how do you dispel all of those rumors, all of those? I mean, our climate is just mistrust today, mistrust of everything, mistrust of people. And that was bred, and I'm sorry to say, excuse me, by the last 4 years of the administration. I'm not saying that he didn't do a good job at getting it warp speed out there. That's fine. But it's just an amazing, I just feel as if I can't explain it, really. I just feel that we're so polarized about this in a lot of ways that we've got to come back together like we used to be. I mean, we've always said, but we've got to come back together like we used to be. And this shouldn't be anything that people are scoffing at. It's a pandemic, for goodness sakes. It's all over the world. The numbers show it. But how do you get around those media hypers that just don't want to, how do you get around that? I think, do you understand the gist of my question?
Yeah, and this is where, Sally, also in clinical sessions, right, where things are highly polarized, it's why we emphasize conversation, right? Because the first thing is to discharge that emotional energy, right? It is to just get beyond it and say, look, I'm just talking to you, Rhonda. I mean, I'm worried about this, right? It's about me, Dana, right? It's not about Fox News. No, it's to the degree that we can, reestablish in real life connections, but it really is almost clinical. Sally?
Dana and Rhonda, this is such a good point that you bring up. And, for some reason, my mind went toward the years and years and honestly still some mistrust with the VA. We're a much different department than we were during the Vietnam era or after, and so, I'm thinking about in particular my work with veterans who kind of grew up in a time when they were spit at for their service. They weren't celebrated. They were shamed and they were called horrible, horrible things. And they were told they weren't wanted and they didn't deserve. And certainly our society and culture has changed that in lots of ways now. And we see parades and we see welcome homes. But when I found myself clinically, prior to being more in an administrative position, when I found myself clinically in those conversations, what I found incredibly helpful, validation, being able to not argue with someone about their experience, because it is their experience, and their experience is incredibly valid and real. But as an agency, we continue to have to do the work to gain veterans' trust. And sometimes they are met with our huge bureaucratic system where things move at a glacial pace, and we have to help provide that customer service that lets them know that we care. And when they call a number and they're sent to 50 million different people and they can't get to the right person, we have to ensure that our customer service skills hears that, and that we continue to engage with them. And I know that's a very different situation that you brought up, Rhonda, but it made me think about the VA and the perspective of the VA over the years, and the need to continue to still get better, and to still work to listen to people and what they need.
Can I say something? This is Tony Hicks. I'm the co-chair of this committee, the Health and Wellness Committee, and thank you all so much for sharing your expertise today and your information. I had challenge getting onto the call today. I was in the general session on my computer, but then when I went to the working group, this session here, I had problems and I couldn't get on for some reason. I don't know, it's just maybe this new platform, but I'm just enjoying this conversation. I am Sally. I am a Vietnam vet, and I do agree. It is a different time now than it was back when vets were coming home back then during the Vietnam era. But I agree with Dana is that it's so important for the conversation. One of the things I remember when I was in the service, of course, I was a young man then, but one thing I remember that I think is still true today, or whether I was here in the States, when we were on a mission, we were a team and we cared about each other because we, especially overseas, we had to protect one another because, we all depended on each other. And so I find that having that conversation with veterans is the starting point of helping people understand why the vaccine is so important. So just talking, having the talk is the start. And if you can't start there, you're probably gonna have a hard time getting someone to understand how important the vaccine is. And like Sally says, you don't have to argue with anyone. I find that that's a turnoff when you're telling someone how they feel. You don't know how they feel, so listen to them. Whether and sometimes it's an age gap. I'm in my 60s now, so talking to a vet that's or a family member of a vet that's in their 30s may not connect with them. So maybe I might have to find somebody closer to their age. Maybe because the person wants to talk to someone that's their ethnic group. So we have to look at those things when it comes to trying to help people understand why they're being hesitant about the vaccine. Because as was mentioned today, there's so many various reasons why people don't want to, they're hesitant. They may want more information. They may be just their experiences from listening to others, like the Tuskegee. That's a lot of African Americans still talking about the Tuskegee Tuskegee experiment. And that was a long time ago. Come on, it was a long time ago. And we've had many Black doctors and scientists that have come along since then. Many doctors and scientists who've gotten shots in their arms. Some of those people are related to these people who don't want to get the vaccine. So the conversation, the piece is very important, and how we can work on getting that started, I think, is a good focus also. But thank you all so much for sharing your information on our working group today. I'm gonna just turn it back over to you because I don't really have the controls here to do what I want to do anyway. But I just want to thank Amy for setting up the new system. I want to thank all the speakers who came and spoke today, sharing information with veterans. I've been taking good notes. I got good notes I'm going to share with my group and my network. So thank you all so much. I turn it back over.
Thank you, Tony. It's great to meet you. And I know Jeremy has been on the call, and as Dana mentioned, there's a plethora of assistance out there and information out there. And Jeremy, I don't know if you just want to preface that and let people know, about the volunteer system that you're familiar with.
Yeah, absolutely. So I work with the COVID-19 National Scientist Volunteer Database, as Dana mentioned, which is a group of about 10,000 scientists from all walks of life, all demographics throughout the US and some internationally. And so we've been able to work with them to find experts in all sorts of different areas of science, but specifically experts that are very familiar with the vaccines and can talk about them from an expert standpoint, but we can find people that community members can relate with. Because the idea is that you want to see some, you don't want to have some random person that's coming out to all the same meetings. You want to have somebody that community members can look to and relate to, that's being brought in through this trusted conversation. And so that's why we're trying to build this really large network of experts so that we can really do that really precise matching to bring in people to help that community level conversation. So that resource is available. If anybody's interested, has any needs that they think that would be useful, be happy to have more conversations about that and see what we can do to set it up. Also, we also have a large number of scientists that are really good at any specific questions. So if you also just have any questions or have something that you're hearing a lot about that's causing problems and you'd like sort of an expert opinion of how you might be able to get around this problem, or simple answers that you might be able to give, we can also chat just about that to provide some direct information if that's ever helpful.
I'd like to just add something. My name is Marie and I'm with US Vets. I'm not a veteran, but I work with veterans. One of the things, Sally, that you mentioned is the validation. I'm a clinician also, and the validation is very important because we can have all these resources and all these experts that there's that on one side and there's that on the other side. So you have both sides loaded with experts. And I think what's happened that is really saddened for me is that we no longer have one place we trust and one place we go when we get the information and all of us are unified in our agreement. I work with a lot of veterans who are on the side of huge hesitancy. And we work with a lot of veterans who are in colleges and they're being shamed or ridiculed or put down for having a viewpoint and opinion. And I think we do more damage and we push them even further to their side because we do that. And I find it extremely sad because it's difficult to have an exchange of ideas. It's gotten to the point where you're attacking individuals personally. If somebody's not wearing a mask, they're certainly labeled as something. And I think it's that level of mistrust that we no longer trust individuals. And it's like we're no longer able to be individuals having an opinion. We're now tribes. If you're not part of this tribe, you are somehow bad. And I think that even pushes people more to their side because as someone who's trying to communicate with them, and I loved, Dana, what you did around that motivational interviewing, around that change talk, which is so critical in every aspect of our life and so extremely valuable when you can get them to engage. But what's happening is they don't trust their professors, they don't trust their leaders, they don't trust their doctors, because everything seems to have a tilt to an agenda. And so I think that's what happens. And when they don't feel like they have a voice, they pretty much say, screw you, I'm going to do what I believe. So engaging with an agenda that somehow we're right and they're wrong is not going to get us anywhere, because we still come. And even when we look at the presentations and we look at the thing, it's always tilting the right side with the correct image and the wrong side with the wrong image. It's so subtle. And our veterans are smart. They went and worked. They fought for this country. And the veterans who came back in Vietnam, they were not the minority. I mean, they were not the majority, and they were sped on and treated horribly. And now they're seeing themselves again. We're that small group. And once again, they're trying to convince us, and they're angry. And you can tell I'm angry because I don't know how to reach them, because they have valid points. Everywhere they go, they're being shamed for having an opinion. And that's the real conversation we need to have. How do we have a real conversation that these people have a true voice and they're not glossed over and said, look at the professionals, look at this. They're glossed over and they're not able to have that validation that Sally talked about. I have a valid concern, and the valid concern goes with A, B, C, and D. There's a track record of things that they have. It's not just the COVID. And so I think that's the real conversation we need to have. We can't gloss over them and validating them. It's like doing a spiritual bypass. Oh, just trust in who you trust, but don't deal with this. We're doing a bypass. And so I don't know how the answer. I just know that I'm equally as frustrated as they are because I can't reach them, and I have to spend a lot of time validating them.
I think one of the answers, and I just thank you, Marie, because you are that trusted person that is not sitting in judgment and allowing the veterans to be exactly who they are and where they're at. So thank you for that.
You're welcome.
Can you hear me? Yeah, I run the Veterans Resource Center, and I work with hundreds and hundreds and hundreds of veterans, and I want to echo what Maria said. Well, especially in the college setting, the majority of all veterans get out, come to community college. I've been there for I've gone on more than 8 years now, and I am also a clinician. And I'm an MFT, but I'm also I'm almost done with my doctorate now in psychology. So I've been doing this a long time, and I'm retired. I was a Navy counselor for 26 years active duty. So I do this a long time. So what she's talking about is absolutely correct. I run a center where people come in and they feel absolutely isolated. The only place they feel that they can talk safe is coming into my center, and they feel like they're safe and protected in the center where they can talk and speak freely in the Veterans Resource Center. Outside of the center, they're saying, oh, I can't talk, I can't speak in the class, the professor's saying this, the students are judging me, this, that, and the other. And so now we can't have a conversation because of the system, the bureaucracy of the education system, where I don't have the power or authority, and I'm pretty sure you guys understand everything about what a bureaucratic system is about. I don't have the power or the authority to supersede anything. So my whole thing is just to give them a safe space, to keep them safe. But I really appreciate, especially what I heard today about the different ways of communication and the validation. And she was talking about the motivational interviewing, but not being, because I don't wear a clinician's hat when I'm sitting in that office. I wear a peer hat, a trusted friend hat. I am not there as a clinician. I'm in my other capacity when I'm at the wellness center, I wear a clinician's hat. But there, I am there to be a transitional advocate of this is what's going on, a sounding board. And my goal is to connect them with internal and external resources like what I learned here in this collaborative, in order for them to better access their resources to more to develop themselves, to be able to be holistic, to learn this process. Because even with all of my experience, I still struggle with exactly what you're talking about today. Every issue that you talked about, I still struggle with it. I cannot come in there. I'm a senior chief. I'm a master chief. You know me. Doesn't matter. They see the world as what they are dealing with today, and to create that bridge of trust in order for my information to even become penetrate. I can learn some amazing things here today. Go right back there. I've got 700-800 people come standing right in front of me, and I bet you 10 of them is listening because of the environment, not because of the information. So we have to do a whole different thing. And I will agree with Sally that the VA has done a masterful job of changing what they're doing in order to help veterans. And I am a big proponent of what we're doing, some great things, that U.S. vets are doing some great things to help our veterans out there. You guys are doing some, but we have to be able to connect with them and get them to use the resource in order to better, to make it more whole, instead of, as someone said before, tribes that exist. You're not one of us. You never served. You don't know what you're talking about. You've never been to Iraq. You've never been forward before. Yeah.
I think that that's a good point, because I work with active duty people, and to be honest with you, I never was in the service. I'm not a vet. I'm a Vietnam era, as you can probably tell, person. And I remember those days of coming back and how well people were treated. But I think that the community does, because veterans, that's a smaller population of the whole population. And we don't always understand what you're feeling as a veteran or a service member. We don't understand the culture that goes along with it. So I think that more information or teaching, or not necessarily teaching, but just letting people know how it was, how it is. This is what you do. This is how it is when you're in the service. And you're told to do what you have to do. And, it's all of those things that go into it. My son is a veteran, Iraqi War Freedom, the OIF, and, came back with PTSD. But I mean, it's just, I think it's just as a civilian, I don't understand. I'm learning to understand, but I don't understand. And I work with active duty caregivers, active duty people. So I'm learning, and I've been doing this a year, and I'm learning what it is that you have to go through as a veteran, a family, military family, the changes that you go through. And people just don't understand. I didn't know or understand that you may be moved every year for the next 25 years or whatever it is. And, the separation, all of that. So I think it's finding the right connections, finding the right conversation. And I don't blame anybody for being skeptical. I have a master's degree in public health, and unfortunately, I know more than the average bear. And so it's hard for me to talk to somebody and just go, don't you see that if you just do it, we'd be done with this? But I don't do that, but that's how I feel inside. So being that public health is a part of my life. Anyway.
I certainly appreciate all you do, and same, Charles, thank you for all you do, and all of you that have been on the call. I know we're a little bit over time. I do have to slide out, so I really want to thank you for this opportunity, Amy. Appreciate it. And Dana, final word.
Well, two quick comments. One, I can stay if there's a desire for a continued conversation. The other thing is just that two other points. One is, we'd emphasize the learning network part of our title. That is if you have ideas, if you have comments, if you have insights, please tell us. This really is a collective process of trying to get smarter around this very, very difficult challenge. The second thing is that we are attending to this larger issue of context. One of the things we are trying to get started is communications that reflect what we're doing, so that you validate rather than pointing fingers via television commercials at people. You say, of course you got questions. You'd be insane not to have questions, right? Those kinds of, and we talk about a process of catalyzing, shaping, and amplifying. So ideally what we would do, and this works in actual shooting war, so I think it will work here, is you show the local behaviors being listened to, validating, that kind of thing. You then you amplify and so you show, because as human beings, we listen and we model, right? This is not news to anybody who's got a clinical kind of background. We model based on what we see other people doing. So that is the larger strategic communications piece. We're trying to engage in that. One of the problems though is the hectoring as well as the bribery, which doesn't work very well, right? I still need to get my Budweiser beer, but all of those various lotteries and prizes and everything, we had a little increase, and then it actually drops below the prior rate of vaccination for a while. So there are larger strategic efforts, and we're trying to shape those. So all of your expressions about that are really well heard here.
All right. Well, thank you, Dana. And again, my co-chair, I don't know if he's on the line, Lewis South, the co-chair of the Health and Wellness Committee, along with myself. We want to thank all of you for coming on today. We know you have other obligations and things you have to do today, but if you need to get in contact with anyone that's on the line today, that was on the line, just contact the LAVC, contact Amy Bravo, and she'll be able to connect you with anyone that was on today.
Yeah, I have this conversation all afternoon because I think
it can go all afternoon. Yeah, it's a good one. Real good one.
It's a good one, and I appreciate everyone's insight, and would like to connect and do this again. This is a great one.
Very good. Thank you all. Thank you all. Enjoy the rest of your day.
You too. Take care now. Be safe.
Okay. Thank you.
You too.
Bye-bye.
Be well.